Good morning or early afternoon. Well, thank you for having me, and thank you to organizers, and particularly Professor Stipp for your continued support of my interest and work. I'll start by saying that I've been involved in neuromodulation since early 2000, and that's more than 20 years. And obviously, I'm a tech-interested man. I believe, however, that our biggest progress will come when we have the right questions and measure them accordingly. So this presentation will try to persuade you of this. I have no conflict of interest to declare. However, my major conflict of interest is that I'm hoping that neuromodulation makes a difference in the patient's lives. But sometimes I have patients where I don't help them. And I'm kind of asking myself, what's going on? What is it that I miss? And unfortunately, like any type of treatment, a lot of things don't work the way we hope. And so I ask myself, who are we treating? Or what? And what is mental illness? Is it the DSM, more ICD type of definition? Should it be symptoms that we look for, or clusters of symptoms, or constructs, like emotional regulation, cognitive control, reward evaluation, etc.? And that's been touched by others, but let's remember that the DSM was built on consensus by people who see patients. Yet when you look at field trials, the DSM-5, for instance, you see this kind of flower there where the petals intersect quite a bit. These diagrams show that a pure patient almost don't exist. They're very rare. Major depressive disorder without anxiety disorder, or without somatoform symptoms, or without panic disorder, or without some level of trauma and PTSD, for instance. It rarely exists in real clinics. And so when you do a clinical trial, you need to eliminate that and just go for the tiny blue part that's only 15% of patients. And then when you try to apply this in the clinic, it doesn't seem to be working. And so DSM-5, the Dr. Lee said that Thomas Insel tried to sabotage DSM-4, but did not succeed. DSM-5 came back roaring. And it's a very poor tool to help us and guide us through treatment, but specifically for neuromodulation, it's a huge problem. And so people are trying to think about how we can go about this. We could look into symptoms themselves, and Bosboom in the Netherlands have spearheaded using AI and deep phenotyping, how symptoms interact with each other. And there's some symptoms that are more important than others. And one way to look at this, he suggests, is that there are symptoms that have sort of like elastics between them. And if the elastics or the connection is too stiff, any change in a specific symptom will pull on the other symptom. But if you have like high connectivity between symptoms, you'll end up, if you only have insomnia and you're bipolar, you may end up having a relapse within 2 days. That's because the symptoms are really closely connected. And in controls, you can have insomnia, but you're not going to get depression in 2 days because there's leeway. And so one way to measure patients is going back maybe to the symptoms and what is the landscape of symptoms of patients and how you address treatment based on the symptoms they have. It would be a type of precision psychiatry, but the symptoms, as was stated before, it's at the end of the spectrum. There's something going on before that. And then there's the high top consortium. It's a bit less dramatic proposition, yet it's a system that would work well for clinicians. It's based on the idea that basically, like for depression, It's part of the internalizing disorders. And in those disorders, you have depression, dysthymia, panic disorder, agoraphobia, general anxiety disorder, PTSD, and then you have thought disorders, externalizing disorders. And if we sought to use this type of system plus DSM-5, we might end up with different results and more promising results in neuromodulation also. And then there's the NIMH RDoC initiative. RDoCs are more abstract. In theory, the domains proposed tap into specific circuits or areas in the brain responsible for negative valence of stimuli, for instance, or positive valence, cognitive systems, especially cognitive control, etc. In theory, different symptoms could be impacted by only one circuit failure. An example of that, cognitive control, can be abnormal in many internalizing, externalizing, and thought disorder. And you could end up, having an impact, let's say, with RTMS on all of those diseases by targeting the same RDoC system. This is an example of what we did in our group, where we published an RDoC manipulation by RTMS. In a positive valence system of RDoC, we hope to reverse the abnormal valuation of drug in tobacco users in a craving state. Usually smokers' anterior cingulate cortex will light up, when they are presented with smoking reward over money. But money is a more abstract reward, like pay me now and I can buy myself a cigarette later. In smokers, the anterior cingulate area of smokers light up more for a cigarette than a conventional reward, money. And so we wanted to see if we could manipulate this, and by applying on a specific fMRI found craving area of the brain and give 1 hertz to inhibit cigarette reward and 10 hertz to stimulate money reward. And this, what you see in the left panel there, where we were able to show that we are able to do that. Basically modify the value of a cigarette reward, and actually increase the money reward over cigarette reward. Whether that actually helps stop smoking, we don't know because we didn't study that. That's the idea of a RDoC. You would measure that and eventually smoking cessation and see if that correlates. And so where should we apply neuromodulation? Should we go anatomically, functionally, very precisely, as was shown, for instance, in auditory hallucination quite clearly? Or should we go for the whole brain areas with larger coils or other type of devices? And it's still a question, because if you look at ECT, it's quite a large area of the brain that's being stimulated or inhibited, depending how you read the literature. And to some extent, what I'll present later, VNS. And yet the data is pretty good. Even it's not very specific, very targeted, the data of ECT still is very difficult to compete with for refractory depression, for instance. And VNS programs, I mean, the latest data that I'll show is quite interesting as far as capacity to maintenance of patients with to prevent relapse. So you could go into specific nerve also in order to tap into the brain. And one of there's many competing technologies emerging. One is transauricular VNS, and there's also a VNS stimulators implant. There's been also a neurostimulator for sleep apnea that was developed, and that's growing through the capacity to mostly the cranial nerves to eventually stimulate the brain. but usually that's a very large areas of the brain. And should you go through the skull or in the skull, or could you go in the skull, but without actually putting a device in it? And so people are trying to also think about how we could go about this. And then would you go, which protocol are you going to use? You know, inhibitory, excitatory, or sometimes you think it's excitatory, but it's not. You don't even know what's doing, but it's working. Like 20 hertz might be inhibitory for hallucinations, but stimulatory for frontal areas. And that's a big problem because we just don't know exactly what we're doing here all the time. And so the new technologies, for instance, here, on the middle panel, you see the classic transcranial direct current stimulation, where you apply big pads and you have electrical fields that you see that are fairly large, and there's some effects there that you can measure, or you can say, well, we're going to do high definition TDCS, and eventually have a much lower, fairly targeted area, where if you're on the target, it's good, but if you're off target, then you have no effect. So it might be a two sides of a coin where you're more precise, but you can miss it more. So that's one of the issues that we have to think about in our field. A new technology is emerging. It's still very much in the development status. It's the temporal interference stimulation. And I think that'll be interesting in future to look at. But it's basically the brain lithotripsy. It's a bit like we use for kidney stones. You would use basically sun waves, but with interference pattern, so that in the middle somewhere, there's a burst of energy, and it actually stimulates neurons. And there was a proof of concept that's been done, and that's been published this year. Very interesting work to come. But also in that same kind of technology is emerging is the focused low energy focused ultrasound, also able to go deep in structures without having to implant patients. So what about RTMS and deep TMS? Because now that's this new kid on the block on the right side, where they go for the more larger regional brain area to stimulate. And on the left, you have the more classic RTMS that we also use quite a bit. And then there's the deep stimulation, where there's some data that suggests that in OCD, for instance, you can have sustained effect over 12 months if you stimulate in the ventral striatum and ventral capsule, which is a very tiny area of the brain, the learning area for habit. However, if you look at the data of stimulated patients that respond, the area that's actually lit up or inhibited is quite large. It's almost all of the orbital frontal cortex, prefrontal ventral cortex. And so it's precise anatomically. When it works, you have to push up the volume of the electrodes, and it becomes a larger area than you thought. But still, it's quite good. So what are we treating, or what circuit we should look for? There's been some very interesting seminal work done in the mid around 2010 by Menon. And basically, there's been parcellization during resting fMRI of brain activity. And there's, from 17 circuits, we can boil it down to 3 major circuits that explain most of mental illnesses and the interaction between these 3. There's anomaly of, there's anomaly of this, CNN, the central executive network, which will account for weak or excessive mental focus, planning, impulse, and sensory inhibition, working memory. There's a default mode network, That's very important in self-reflecting, mental activity, creativity, thought production, and ruminations, self-awareness, and finally, salient stimuli mapping in the centers SN, which also interacts with the two others. And in a way, mental illnesses are somewhat of an interaction between the three that's going abnormal. And when you look at what we're doing with our TMS or brain stimulation, is we're not treating diseases. We're actually trying to modulate some circuits. And you can imagine that if you could have results where the same treatment, a bit like medication, can treat many diseases if they have in common a central executive network issue. But they might also have a saliency network problem, but not in all patients. And then you also need to tackle that as well. So how can we measure this? The Fox group in California has looked into, for instance, depression, post-stroke and after brain lesions in various data sets around the world. And what they looked at, and they basically said, well, there's no real specific area of the brain that accounts for a post-stroke depression. The stroke can be anywhere in the brain, and we can't really predict why the depression happens. Yet, when they looked and mapped this over a circuit, bingo, they found that they all match for F3 area, dorsolateral prefrontal cortex left. And so this area of the brain is very important. It's a hub. It's a very important hub, probably more important than we thought, not only for cognition, but even for things as cognitive control, but also a portal. The one that look into Star Trek, a portal into other system in the brain. And we know at least that with our TMS, that's where we aim for the treatment most of the time. And that's a good thing because it seems to be a very important portal. For instance, in depression, same groups have shown and others that this area is linked with what we call the cingulate cortex, responsible for depression, ruminations, and feelings of depression, but is also an important hub that controls the default mode network, which is important for depressive ruminations. I'm a bad person. This life sucks. All these types of thoughts. If you have more cognitive control, you'll be able to inhibit them, and you're going to be able to inhibit also sadness through activity of the dorsolateral prefrontal cortex by increasing that activity. And actually showed that there's an anti-correlation. The more active frontal area you have, the less active salient network or CG25 area that is active, the less active it is, you have less pain or psychological pain, if you will. And that's what you see here. There's a clear correlation, anti-correlation between these spots. And so what they've been suggesting for many years now is you anti-correlate, you do fMRI anti-correlate the F3 area to the area of the cingulate that's more active, and that's where you put your coil and you treat. That's interesting, but very, very expensive to do. Going back to the rumination story, we looked at data and whether we could see whether baseline rumination in our patients would predict response. And we have some prediction with our 20 Hz protocol in depressed patients. And rumination has been shown to be one issue of an overactive default mode network. And that's usually what's found in some depression. and that RTMS tends to be able to inhibit the default mode network, as I just stated. And so that's kind of a possible indication of how this is working. Going back to the F3, so if it's too expensive to measure by doing fMRI, there's other ways to try to find the right spot, the good F3 spot, if you really, for precise RTMS. And so the Arns group in the Netherlands have suggested to use the neurocardiac navigation, basically, having a scope. And when I stimulate the right spot over F3, that's where you have the most deceleration of your heart rate. You have actually a parasympathetic tone. And then if you move it just a little bit around, you have less of that. And so if you're on the right spot, the patient tends to have a decreased heart rate frequency. And this is where you should do your treatment. Others have said, well, F3, that's also important for working memory and task orientation. And so if I stimulate over the right spot and asking someone to do some computer task, they won't be able to do it for a fraction of a second. And so they looked at how you can impede the cognitive control temporarily the most. And that would be the spot where you would treat the patient. So people are looking in very interesting and elegant way to try to pinpoint the area, but in a live way, a functional way. And this is the study that I just talked about. Well, finally, you could also, do many things at the same time. You anti-correlate, you do intensive, like 10 sessions a day for 5 days, the so-called SAINT protocol from California. And then you say, well, this response rate or like 70% remission is incredible. It's very interesting. It hasn't yet been replicated because it's like the whole thing. What actually works in the box, we're not sure. Because we tried to replicate that and we couldn't see any changes, but we didn't do the fMRI. So maybe that's because we didn't have the fMRI, or maybe it's because you have different patients. We don't know. Deep TMS works just as good as regular RTMS, basically. And it's better than sham. And you don't have to do all these precise measures, but you're, selecting a whole brain area. Direct current stimulation works maybe a little bit. So it's better than placebo, okay? But it's not as good as Celexa for normal depression, not resistant depression. So there probably is a place for this in the future, but we don't know exactly where. Could it be after a successful RTMS program and, for relapse prevention? We don't know yet, but it's very interesting. And I'm hoping that the high definition TDCS will make a difference. And when you give RTMS, so there's not much studies after 12 weeks of treatment, but the patients have diseases for years. Depression is a relapsing, remitting disease. They get better, but they relapse. So we need to focus on also long-term efficacy. And this is a slide that shows that long-term efficacy is not that good with RTMS alone. But if you have a clustered maintenance when patients have a little bit of symptoms, then you have a better, less relapse. This is RTMS plus antidepressant and RTMS in the green and blue line, and just antidepressant in the red line as far as relapse over 12 months. So it actually works for maintenance, but we don't know the exact recipe should it be for life. So that's why we have been interested in VNS. VNS is not a precise mechanism. It's I like to say the Christmas tree type of thing. It lights up everything. It lights up the brain stem. We know that it stimulates the locus coeruleus, the dorsal raphe, the CRF, It eventually stimulates the insula, amygdala, hippocampus, cingulate. So it's a really broad type of stimulation of the brain. And so how it actually works, nobody knows. Could it be through inflammation, inflammation changes? We know that the vagus nerve also stimulates the spleen, and it's been shown. There was some preliminary data from the Grenoble group in France that shows that it might be good also for Crohn's disease, and so that might be one of the ways it works. And so we've been publishing around VNS for some time now, and our cohort is now 30 patients, and we tend to have about 40% of bipolars with a response at 2 years of 71% and a remission at 60%, 64%. And so it's pretty good for those very, very refractory patients that were usually non-RTMS or ECT responders. And the data is pretty much like this in the literature now. This is old data that basically says that if you respond to VNS, you have a 70% chance to be still a responder at 2 years. If you respond to medication at some point, or probably RTMS, and I don't do anything else, in 2 years, you only have 10% chance of still being remitted. And for my last slide, or just before my conclusions, there's been a registry in the US, and that basically tracked what happened with patients who were implanted with VNS. And basically, this is over 60 months, so it's 5 years. It's a very long data for refractory depression that shows that patients get better and better and better over the years, which is the opposite of what you usually see with regular treatments. And on average, you'll end up having close to 50% of patients will have close to remission or very good stabilization of their disease over the long term. So in conclusion, new technologies are coming fast with ingenious ways to modulate the brain faster than our models about symptoms, relation between symptoms, circuitry, and a quite rigid taxonomy of mental illnesses. And for the neuromodulation, it needs to be updated. We need new taxonomy to help us, to guide us to see results. Some tech are good for acute care, but not great for long-term care, and maybe vice versa. And every technology will need to find its ecological niche. Where does it fit in the trajectory of a patient? And the debate between super targeted versus with fMRI guided versus broader neuromodulation strategies will continue to be a debate in the future, I believe. Thank you very much.